Good morning. The purpose of this presentation is to discuss the research and significance of the role of iron within the body, as well as the blood disorder anemia, which results from its deficiency. I will be examining current research and presenting information on the etiology, diagnosis, treatment, and prevention of anemia, as well as highlighting the influence of genetics and relevant assessments of nutritional status. Iron is an essential trace element critical to the transport and storage of oxygen to cells and tissues. It also functions to facilitate a series of biochemical reactions such as DNA synthesis and repair, hemoglobin synthesis, energy metabolism, and cell proliferation. It contains both heme-containing proteins such as hemoglobin, myoglobin, and cytochromes, as well as non-heme-containing proteins, both of which are crucial to a number of metabolic pathways. It is also a carrier of electrons and able to bind with cofactors, making it an essential component to a number of redox reactions. It is through this binding capacity that it readily cycles between its ferrous and ferric forms. A normal Western diet is thought to provide between 10 and 20 milligrams of iron daily, of which only 5 to 10% is absorbed, which equates to around 1 to 2 milligrams. An individual's iron status is dependent on their iron intake, losses, and bioavailability. The absorption and storage of iron is regulated by a peptide hormone, hepcidin, which binds to ferroportin, resulting in its eventual degradation. Iron is primarily absorbed in the jejunum through enterocytes, where it binds with the transport molecule transferrin. Intestinal absorption of iron is dependent on transferrin and ferritin stores, erythropoietic rate, and the bioavailability of dietary iron. Transferrin has a binding capacity of 2 iron atoms per molecule and is reutilized after transporting these molecules and donating them to cells. Dietary iron is available in 2 forms, heme from animal source and non-heme from plant source, with heme iron being much more readily absorbed. The absorption of iron is regulated by at least 3 proteins. The first is divalent metal transporter, known as DMT1, which occurs at finger-like projections within the small intestine, known as villus tips. The second and third are HFE and ferroportin-1, which are found at the basolateral surfaces of enterocytes. DMT1 functions to determine the amount of iron absorbed and is controlled by the degree of expression of HFE, which is increased during iron deficiency. The storage protein for iron is ferritin, which can be found in all cells of the body, as well as fluids within tissues. The plasma concentration of ferritin usually correlates to total body iron stores, making it a relevant assessment when diagnosing disorders relating to the metabolism of iron. The amount of iron absorbed by the body is inversely related to the amount of iron stores and the rate of erythropoiesis. This is the process by which the body generates new erythrocytes, and folate, vitamin B12, and iron have crucial roles in facilitating its reaction. Iron homeostasis and erythropoiesis pathways essentially regulate each other in order to ensure optimal delivery of oxygen in cells and tissues. Iron deficiency is the most common micronutrient deficiency worldwide, as well as the most prevalent cause of anemia. The predominant etiology of anemia is acute or chronic blood loss from the gastrointestinal tract. This is common in conditions such as hemorrhoids, diverticulosis, peptic ulcers, colitis, and hookworm infections. 1 milliliter of blood contains approximately half a milligram of iron. Therefore, a steady loss of as little as 3 to 4 mils per day can quickly result in a negative iron balance. Other etiological factors leading to iron deficiency anemia include increased requirements during growth phases, menstruation, pregnancy, or after blood donation, increased blood loss or blood cell destruction through urine, stool, or trauma, decreased absorption due to inadequate diet, micronutrient deficiencies, illness, or use of medications such as aspirin, antibiotics, or antiretrovirals. Decreased release from iron from storage within bone marrow. Genetic disorders such as glucose-6-phosphate dehydrogenase deficiency, alpha thalassemia, and sickle cell disease may also be contributing factors. Mammals contain two genes which encode for transferrin receptors. Type 1 is believed to have signaling functions in erythroid cells, which have a role in iron uptake. Characteristic symptoms of iron deficiency anemia are chronic fatigue, hair loss, pale skin, lightheadedness, and restless leg syndrome. Physical findings may include pallor, glossitis, stomatitis, and angular cheilitis. Individuals presenting with these symptoms are generally asked to have a full blood count and film taken to confirm a reduced hemoglobin concentration, reduced mean cell volume, microcytic hypochromic red cells with pencil and target cells, reduced serum ferritin, elevated soluble transferrin receptor levels, and increased transferrin iron binding capacity. In order to sufficiently assess iron status, individuals should be evaluated for a number of biomarkers to give a valid review of clinical indicators. Serum iron tests should not be solely used, as it is not only decreased in iron deficiency, but also in inflammatory disorders, acute infection, immunization, and myocardial infarction. The following table indicates measurements and reference ranges used to indicate iron stores, tissue iron supply, and available functional iron. The gold standard for the diagnosis of anemia is the Pearls Prussian blue bone marrow stain. This, however, is highly expensive and invasive and therefore not commonly performed. Positive indicators for iron deficiency from the bone marrow stain include ragged, regular cytoplasm within erythroblasts, as well as an absence of iron from within stores. Biomarkers detected in serum are routinely used, with serum ferritin being the most effective. According to the World Health Organization, the diagnostic criteria for anemia includes individuals with hemoglobin levels below 12 grams and ferritin below 15. Assessment of total iron binding capacity and serum iron levels may be used, however, these may be affected by factors such as inflammation, aging, and nutrition status, resulting in poor sensitivity. The treatment of iron deficiency anemia varies according to the severity and presence of other conditions. Prior to any treatment, the direct underlying cause of anemia should be identified and assessed. Most individuals presenting with anemia are given oral iron preparations containing ferrous sulfate, along with vitamin C supplementation to aid and maximize absorption. Oral administration is preferred as it can be administered economically and safely. Low-dose preparations of 100 to 200 milligrams of elemental iron given orally 3 to 4 times a day are used to minimize side effects such as pyrosis, constipation, and loose stools. Red blood cell transfusions may be performed on individuals with critical illness such as acute sepsis or traumatic brain injury, or those who show insufficient response to oral preparations. In order to prevent this condition, individuals should be educated on the significance of maintaining a diet containing adequate amounts of heme and non-heme iron, particularly if they fall within a group at higher risk of deficiency. Those who follow vegan or vegetarian diets are recommended to increase their intake of ascorbic acid, as it is a powerful promoter of non-heme iron absorption. In summary, iron is an essential element of all living organisms, and as there is no natural mechanism by which the body can excrete it, its absorption is highly regulated. Its deficiency occurs in varying degrees of severity and may stem from a number of etiological factors. Iron deficiency anemia is the most severe form of iron deficiency and is characterized by low iron stores, low serum iron concentration, low saturation of transferrin, and low concentration of hemoglobin. Thank you.